Welcome to this GE HealthCare educational series on Surgical Pleth Index monitoring. This measurement is a part of the GE HealthCare Adequacy of Anesthesia concept. It relates to surgical stimulation causing sympathetic responses of the autonomic nervous system, how such responses are normally suppressed by analgesics, and how those responses can be objectively measured. SPI provides information of the responsiveness of adult patients to surgical stimulation and noxious stimulation during general anesthesia, and it helps the clinician to titrate the level of analgesic medication according to an individual patient need. In this third video, we will be covering the SPI monitoring setup and helpful advice for monitoring optimization. Let's get started. The GE HealthCare SPI monitoring solution for depth of analgesia consists of 4 components: the CareScape Patient Monitor, the CareScape Monitor SPI software license, the TrueSignal SpO2 sensor cable, the TrueSignal SpO2 sensor. The SPI algorithm is indirectly derived from peripheral plethysmography. It is therefore a continuous, non-invasive measurement. SPI has been developed for finger sensors and therefore cannot be measured on other sites such as the ear or toe. After placing the SpO2 sensor on the patient's finger, a learning period of about 2 minutes will be initiated. During this learning period, the SPI trace is colored in gray. Once the trace turns purple, the SPI information is ready to be used for clinical evaluation. SPI values are updated every second using a 15-second averaging window, therefore representing the patient's status in real time. SpO2 sensor should be applied near the beginning of the case to allow the SPI algorithm to complete the learning phase and to store the patient-specific SPI steady state. SPI is not intended to be used in awake patients, but only in fully anesthetized patients. SPI algorithm uses peripheral finger pulse wave characteristics to create a single numerical value that correlates with the level of sympathetic activation. The SPI range between 20 and 50 for achieving an adequate analgesia has led to good clinical outcomes. Thus, SPI values above 50 may indicate a nociceptive event or inadequate analgesia administration. For example, in some studies, when the SPI value changed suddenly by more than 10 points above the 50 threshold, the opioid infusion rate was accordingly increased to resolve the manifested nociceptive event. In further studies, a more specific evaluation of SPI index variation following surgical stimulus has been proposed as follows. SPI rapid variation of 10 points above steady state was found to be the threshold for movement in the patient group receiving an inadequate remifentanil dose during tetanic stimulation. In this group, the return to steady state was slow and prolonged. On the contrary, patients in the control group receiving an adequate remifentanil dose during tetanic stimulation only manifested a slow and slight SPI deviation from steady state. Also, the return to steady state was rapid. These findings suggest that if SPI rapidly increases above the steady state trend by 10 or more points during surgical stimulation, inadequate analgesia may be reasonable to assume. Nociceptive balance may therefore be re-established by immediately readjusting the opioid dosage. The SPI measurement is to be used for unconscious and fully anesthetized adult patients during general anesthesia, and it is not intended for use in children. The effect of certain potentially confounding medications, artifacts, and surgical interventions has been evaluated. For example, SPI should be reassessed in case of poor pleth signal, especially in elderly patients at low blood pressure or important hypovolemia. In case of effects of vasoactive medications like atropine, or cardiac medications like beta blockers, as well as electric cardiac stimulation such as a pacemaker. In case of a shift in the patient's posture that changes the balance of the autonomic nervous system, therefore having a marked effect on the SPI absolute value. However, it does not suppress the reactivity of the SPI values. It is therefore recommended to relearn the SPI measurement once the patient has been repositioned. Finally, SPI measures responses, and therefore it does not provide information on the effects of analgesic drugs in the absence of stimulation. If there is no stimulation, there are no responses to measure, independently of the analgesia level. When seconds count, in a demanding and multitasking environment like the OR, the balance view offers a prompt visualization of the patient's adequacy of anesthesia by combining the representation of entropy and SPI parameters. The white dot reflects the real-time evolution of both entropy and SPI parameters. When the dot moves away from the target region, it may indicate inadequate level of hypnosis or analgesia. The dot's tail represents a 1-minute trend which, depending on its direction, may reflect patient responses to surgical stimuli, as well as inadequate titration of opioids and/or hypnotic drugs. Visualizing patients' responses to changes of anesthesia conditions may help save valuable time on responsiveness to analgesia and depth of anesthesia administration. Thank you for watching this video series on SPI monitoring.